Hey guys, so we're going to talk blood and electrolytes. For our patients, it's generally split up into a CBC and a BMP. Our CBC is going to be our complete blood count, which is going to look at our erythrocytes, which are our red blood cells, leukocytes, which is our white blood cells, which can be subdivided into our lymphocytes, our neutrophils, monocytes, eosinophils, basophils. We'll talk about those. Hemoglobin and hematocrit, which is what we care about when looking at if our patients are anemic or not, and our platelets. And then in a basic metabolic panel, we're going to look at sodium, potassium, carbon dioxide. Remember, this is venous carbon dioxide, so it's going to have a little bit different lab values in arterial, chloride, calcium, glucose, and our renal function, which is going to include our BUN and our creatinine. So our blood components can include plasma, red blood cells, white blood cells, and platelets. Our plasma makes up a little more than half of our blood itself. That's what's going to contain mostly water, our proteins, specifically albumin, our electrolytes, and then our dissolved gases, which is like our CO2. We get our plasma out from our blood. We're able to separate all of this through plasmapheresis. And that's when they're going to be able to pull and look at like our electrolytes and our BMP. Next, we also have our red blood cells, which is about 45% of our blood, and then white blood cells and platelets combined make up less than 1% of our whole blood. So these are our red blood cells. Okay, they generally live for about 120 days. Our spleen and our liver hold our red blood cells, and they also play a big role in breaking down and removing any of our red blood cells that aren't working as well or that are old. And then our red blood cells are from our bone marrow, which is stimulated by when our kidneys release erythropoietin, because they also excrete some of our red blood cells. Your erythrocytes, so these are going to be what carries oxygen to our tissues and brings carbon dioxide back to the lungs. They do not have a nucleus to make more room for the oxygen to sit on. So they contain hemoglobin, which we'll talk about. That's what makes them red, is the iron in the hemoglobin. So hemoglobin, so normal levels for males are 14 to 18, females 12 to 16. Again, wherever you work might have different values, so just know your facility's ranges. Here in Montana, sometimes we'll see higher ranges just because of the elevation. So people who live in a higher elevation tend to have more red blood cells and a higher hemoglobin count, just because there's less oxygen in the atmosphere. At sea level, atmospheric oxygen is 71%-ish. Here it's lower. So hemoglobin is the protein in our erythrocyte that carries oxygen. We can have a normal red blood cell count, but if those red blood cells are too small, if they're too big, they're not the right size, or if they're lacking hemoglobin, then they're useless. Don't really care what our red blood cell count is. We want to know what that hemoglobin count is. Each hemoglobin carries 4 oxygen molecules, and our red blood cells can have millions of different hemoglobin in them. Again, most important component of our red blood cells, low levels can indicate anemia. That's it on hemoglobin. Next is our hematocrit. So our hematocrit is what percentage of our red blood cells what percentage of our blood is red blood cells containing hemoglobin. So it's just red blood cells divided by our whole total blood. We use this for fluid volume status. It can tell us a lot about hydration status. When we have a higher hematocrit, it can tell us that we're dehydrated because we have a higher concentration of red blood cells within our total blood. Lower can sometimes indicate like fluid overload or fluid dilution, is what we'll talk about. Okay, so next we're going to talk about our leukocytes. Our leukocytes are our white blood cells. These are our immune cells, and there's multiple different types. So our neutrophils tend to make up most of our white blood cells. This is going to be our first line of defense. We're going to see neutrophils in acute infections, acute stress, acute inflammation. Okay, so somebody has an MI, they can have high neutrophil counts. That doesn't necessarily mean that they have an infection of some sort, but just because of that stress to the body. We use neutrophils to determine if we have like a left or a right shift. If we have a lot of immature cells, so it's going to be a high level of bands, which we can talk about more like on clinical if we see it. We don't always order like a full CBC with a differential is what would tell us this. But that will be our left shift. Left shift is going to be a pretty severe acute infection. All right, we ran out of our mature neutrophils, and all we have left are our immature neutrophils. Next are our lymphocytes. So these are going to be our second most abundant. These are our T cells, these are our B cells. These are our cells that go around, recognize the antigen, and then bring in the appropriate white blood cell. We'll also talk about monocytes. So monocytes are going to come in, they're going to break down an infection. They're going to come in after the neutrophils. Okay, these are our Kupffer cells in the liver. There are osteoclasts in our bones, and then our macrophages within our immune system. So they're going to go in, they're going to eat up all the little germs. Generally we see this with like chronic inflammation or chronic conditions such as like lupus. They might have a higher monocyte count. Eosinophils, so these make up a pretty small part of our immune system, only about 1 to 4%. Again, we see this in chronic inflammation, allergies, and parasites. So our asthmatic patients, our seasonal rhinitis patients might come in with an elevated white blood cell count. When we take a further look, we see a high level of eosinophils, or that rare like patient with a parasite. And then basophils, again, very small part of our immune system, inflammation and allergens. So when we're looking at our critically sick patients, generally taking a look at those neutrophils and lymphocytes. So next we're going to talk about platelets. So platelets are our little thrombocytes. Again, they're a pretty small component of our blood, and they form clots. Their job is to have homeostasis, right? We have a cut, a nick, and some sort of blood vessel. They're going to go in, they're going to clot it so that we don't bleed to death, which is kind of nice till it's not. So they are going to adhere to the vascular walls. So we can see in this, our little platelets are going to start adhering, and once one platelet is activated, it is going to continue to release thrombin and ADP in response to this tissue injury, which is going to activate more platelets, which are going to continue to release thrombin and ADP, which is going to tell our liver to activate fibrinogen, which fibrinogen is going to be like the rebar that keeps this blood clot together. When we have low levels of platelets or thrombocytopenia, this is generally from genetic conditions, sometimes such as like hemophilia. Heparin can cause low platelet counts, and that is a condition called HIT, heparin-induced thrombocytopenia. When that's the case, we discontinue their heparin and then switch to other treatment methods to prevent clotting. Sepsis, trauma, bleeding, hemorrhage, all of that can cause low platelet counts, as well as some endotoxins. High platelet counts, so thrombocythemia, which is a high platelet count, can be from bone marrow malfunction such as cancers, some blood mutations, and then some inflammation. We can see a higher platelet count. Okay, so I'm going to talk about our electrolytes, and what they do. So we've got sodium, potassium, calcium, bicarbonate, chloride, phosphorus. When you have like a basic metabolic panel, we don't have all of these electrolytes. This would be in a complete metabolic panel ordered by your doctor. So sodium is an active cation. It's the most abundant extracellular electrolyte. So when we're looking at this is all extracellular. This is what's in the blood serum. This is not what's in like our actual cells. So it is regulated by the kidneys, right? Our kidneys, salt follows water, water follows salt. That's all in our renal system. It's important for maintaining our extracellular fluid volume, so fluid within our interstitial area as well as like within our bloodstream. It's necessary for nerve and muscle function, especially like within our brain and spinal cord and our heart. Blood pressure, we're going to get to that RAS system, and then important for hydration. Hyponatremia is when we have a low sodium level, less than 135. This is the more common than hypernatremia. Hyponatremia can be from like heart failure, hemodilution, so we have too much fluid on our patients, low sodium intake, alcohol abuse, water toxicity. Those can all cause a low sodium. Again, we're going to see some neural problems, so sometimes we can see confusion, lethargy, not as awake and alert as they usually are. When it's really bad, we can see seizures. So when we correct a low sodium, we want to go really, really slow. Generally, we'll correct it. We'll start with like a fluid restriction, maybe some diuretics, get that extra fluid off before we start looking at sodium replacements. Start with oral pills, and if that isn't working, then we can go to some of our solutions. So even like 0.9% NS or normal saline can sometimes work to help bring up a sodium. If not, then we'll have to move towards like our hypertonic solutions. So our hypertonic saline is a very dangerous medication because if we correct the sodium too quickly, we can cause osmotic demyelination. So we have that high sodium level in our extracellular fluid. Our intracellular, all that water is going to rush out from inside the cell to outside the cell, causing demyelination of our nerves, which is not great. Leads to cerebral edema. So when we're correcting hyponatremia, we just want to go 4 to 6 milliequivalents per liter in 24 hours. We want to go really, really slowly. Hypernatremia can also be related to dehydration. These patients might be super thirsty, irritable. They can have some muscle jerks. Generally, we can treat this with just fluids to rehydrate these patients. Potassium is another big electrolyte. Most of the potassium in the body lives within our cells. In order for potassium to enter the cells, though, it does require a little bit of insulin. So our patients who are diabetic, especially type 1, where they don't make any of their own insulin, will want to watch their potassium levels when they come in and we're taking care of them. So potassium is needed for, again, regulating our cardiac rhythm. It's very important in that muscle and nerve function, as well as our renal function. Potassium plays a big role in the action potential of all of our cells, so getting our cells to work. It's needed for ATP production in our muscles and in our cardiac muscles as well, which is where we have our sodium and potassium pumps. Sodium comes in, potassium comes out, creates energy. It's regulated by our kidneys. So hypokalemia, so anything less than 3.5, our patients can be weak, have some fatigue, might see some muscle spasms, and bradycardia. So we're going to have a slow heart rate. Treatment for hypokalemia is just replacing it. We can do oral tablets. We can try to increase some like their leafy greens that they're eating. Another thing we can do is IV replacement. So in a peripheral IV, we do 10 milliequivalents an hour. In a central line, we can do 20 milliequivalents an hour. So when we give potassium, we want to give it really slowly, and they should be on a cardiac monitor, because if we turn them into hyperkalemic, we can actually cause some dysrhythmias. So then in hyperkalemia, so greater than 5, we're at risk for arrhythmias, especially like some of our lethal arrhythmias. And then we can even see like peaked T waves on our 12-lead EKG. Treating hyperkalemia, we want to give insulin, right, because it's going to push that potassium back into the cells. If we're giving insulin to not control blood sugar, then we're going to want to give glucose. We can also give them like D5 in water, and then there's another medication called Kexolate, which will help them get rid of that excess potassium in their stool. If we're seeing arrhythmia, those, we want to act quickly and give some IV insulin. Regular insulin can go in your IV. Causes for a low potassium are diuretics, which like our loop diuretics, GI loss and nausea, vomiting, diarrhea, hyperkalemia, any of our kidney disease, so even like an acute kidney injury or chronic kidney disease or rhabdomyolysis, can cause a high potassium level because our kidneys aren't able to excrete it. Addison's, and then again type 1 diabetes if we don't have that insulin availability. Some other things can also be like our immobility, so our patients, especially if you think like our critically sick patients who are just laying in bed all day, that can break down muscle tissue, break down cells, which will release that potassium. Okay, so we'll talk about calcium. So we get most of our calcium through our GI system, and then from there it's able to be broken down by activated vitamin D or calcitonin. Our calcium is important for our bones and our teeth health. It's also really important for muscle contractions and nerve impulse transmissions, heart function, blood clotting. A lot of our hormones are calcium dependent, and then we need it for digestion as well. Our parathyroid controls the breakdown of our calcium from our bones, as well as renal excretion of calcium. So that's going to be, again, kidney excretion, and then like our bone demineralization and reabsorption. So breaking down our bones if we need more calcium, or putting calcium back into our bones if we have enough. Calcium is albumin binding, so when we look at our calcium levels, we also want to look at our albumin level, because if we have a low albumin level, we can have a falsely high calcium. Hyperkalemia can be caused by hyperparathyroidism, GI upset. These patients might look like they're thirsty because it's going to have the sensation of dehydration and have some weakness. And then hypokalemia is when we're going to see that Korsakoff sign. So when you touch your patient's face, it'll twitch 3 times. Or the Trousseau sign, which is when we put a blood pressure cuff on their arm, and their arm's going to kind of be rigid and spastic. We can replace calcium orally. We can also give calcium gluconate, which is a medication we, again, want to give really, really slowly so we don't cause any lethal dysrhythmias for our patients. So bicarbs, we look at bicarb both arterial and venously. They're not too different. Arterial is going to be 22 to 20, our venous is going to be 23 to 29. Bicarb is a byproduct of metabolism. That's why it's a little higher on the venous side, because our venous is our byproducts of metabolism. It helps with our acid-base regulation. It's reabsorbed, filtered, kind of produced as well in the kidneys to be our pH buffer. So if we're too acidic, our kidneys are going to reabsorb more bicarb so that we become less acidic to increase our pH. When our patients are acidotic, we can give them bicarb intravenously, either in a push or in a drip. And if they're alkalotic, then we can, if they're not compensating with their kidneys, with their lungs, there's a few different nursing interventions we can do to decrease the alkalosis. Okay. Magnesium, this is an electrolyte that we don't see on our basic metabolic panel. We would need a complete metabolic panel to assess this. It's necessary for ATP metabolism and then also needed for calcium reuptake. So anything that needs calcium needs magnesium, such as our muscle and our nerve function, as well as some of our neurotransmitter release. When we are hypomagnesium, so we have a low magnesium level, we can see weakness, we can see torsades, which is a lethal cardiac rhythm, and our hyperreflexia, which you guys might remember from OB. Hyper, so we have a high magnesium level, we can see hypertension, GI upset, and decreased reflexes. Causes of a high magnesium can be an acute kidney injury or chronic kidney disease. Right, our kidneys aren't able to filter that magnesium out. High intake, and then some of our medications like lithium or our PPIs. Low magnesium can be from vomiting, diarrhea, as well as just like a little intake or even sometimes like hemodilution. We can treat hypomagnesium by replacing it with orals or with IV magnesium replacement. Again, we want these people on a cardiac monitor. Also, magnesium can be used as a broncho and a vasodilator. So we want to be watching these patients' respiratory rate, work of breathing, as well as their blood pressure. Next we have chloride. Chloride is important for fluid balance as well as our acid-base balance. It's part of our anion gap. It's a negative ion, which negative ions are less acidic than our positive ones. Most of the time we look at chloride because it's a partner with sodium. When we have too high of a chloride, that can tell us that we have a metabolic acidosis going on. And then low chloride we can sometimes treat with just replacement. And then we have phosphorus. So phosphorus again is needed for the metabolism of ATP. It helps with bone and teeth mineralization. It's controlled by our parathyroid gland as well as our kidneys. So when we have a kidney injury, we can see a high phosphorus level. We can try to treat some medications, but generally if their phos is high, that's meaning that we need to move more towards dialysis. Okay, so last is carbon dioxide. So it's a little confusing with how this is measured because the top one is in millimoles per liter and then arterial is in millimeters of mercury. For CO2 on the venous side, it's normally 41 to 51 millimeters of mercury because we're going to have more CO2 in our venous blood because again it's a byproduct of metabolism. We're measuring it on its way to the lungs. It hasn't been expired yet. Again, managed by the lungs helps with our acid-base system. If we have a metabolic acidosis, we're going to breathe more to release more CO2. Metabolic alkalosis, we're going to have our patients who are breathing a little slower to retain that CO2. We also see CO2 retention in our COPD patients. And so for them, their kidneys tend to try to compensate to monitor or to maintain that normal pH. And that's it. If you guys have any questions, please let me know.